Hello everybody, welcome to Ultrasound of the Month, this time for October 2013. Today we have a special guest, a senior anesthesia resident, Emily Wang. We have no disclosures. Good morning everybody, my name is Tom Edrick and this is Emily. Emily, today we had a very cool case that we're going to present that occurred here in the thoracic pod on a Thursday morning, first case EPP. So let's look at this patient's history. She's 62 years old, presents for pneumonectomy for cancer. So you're working with Emily today. In quick succession, she efficiently places a thoracic epidural catheter, a radial arterial line, induces general anesthesia, then intubates with an 8.5 single-lumen endotracheal tube. Then she performs bronchoscopy with a surgeon watching, and then she places a number 37 left double-lumen endotracheal tube for lung isolation. So a very busy case, but typical of the fantastic thoracic cases we have at the Brigham. Now she is placing a right subclavian central venous catheter. Things are going smoothly, but then after placement of the central venous line and while placing on the sterile dressing, the patient coughs, you notice high airway pressures, and the patient desaturates. So while giving propofol and vecuronium and switching the vent to pressure control to limit pressures, you're thinking, what could be happening? Could it be a pneumothorax? Let's do pleural ultrasound and check. Last month we did pleural ultrasound. Just to repeat the basics, here we have the probe placed between the ribs, looking at the pleura. We expect the parietal pleura and the visceral pleura to be in apposition and sliding, showing us the characteristic artifact. This is what we see in our patient. We see a rib artifact, we see parietal pleura, then we see dark hypoechogenic material, and then we see the lung with the visceral pleura sliding way at the bottom. So this most likely represents pleural effusion, which is not unusual for this type of disease. Placing M mode through shows the same thing. We see a line corresponding to the parietal pleura and a line corresponding to the visceral pleura. In between we see pleural effusion, and down here the classic sandy beach sign. Just for reference, on the contralateral non-operative side, the lung slides just fine. There's no pleural effusion, there's no pneumothorax. Applying M mode shows the classic sandy beach sign. So, it's not a pneumothorax. Maybe it's an airway problem. Let's do bronchoscopy again and check the position of the double-lumen endotracheal tube again. We did bronchoscopy earlier after initially placing, but maybe something has changed. This image shows what we see when we look down the tracheal lumen of the left double-lumen tube. Just for reference, the arrow points at the left mainstem bronchus. This arrow points at the carina. This is probably primary carina. So this endotracheal tube is too deep. The tracheal lumen is abutting the carina, possibly leading to obstruction when ventilating into the right lung. So we pull back the endotracheal tube. Now it's properly positioned. The arrow points at the blue tracheal cuff of the left-sided double-lumen tube. And on the upper right, we see the right mainstem bronchus. Look what happened when we pulled back the endotracheal tube. You see the pressure tracing actually decrease at the very moment we pulled back the double-lumen tube. Now let's watch Emily as she repeats bronchoscopy to verify positioning of the endotracheal tube.
Yep, filming.
Does everyone recognize the takeoffs of the right upper lobe? Typically they are the apical, the anterior, and the posterior segments. Does everyone recognize the right middle lobe takeoff here? And the lower lobe takeoffs? So what happened? We inadvertently advanced the left double-lumen tube too far, causing obstruction because the right main stem bronchus was obstructed. In addition, the bronchial tube, the left side, might have been advanced past the left upper lobe, which would have further impeded ventilation. So the moral of the story is, check the airway soon and often, but keep in mind that you can also rule out a significant pneumothorax using pleural ultrasound. This concludes the ultrasound of the month for October. See you next month.